Your patient's leg is slightly swollen, but it could be the silent start of a deadly emergency. This single observation, seemingly minor, could be the first and only clue before DVT becomes a life-threatening pulmonary embolism. As a nursing student preparing for the NCLEX, and more importantly, for a career at the bedside, your ability to spot the signs of a clot is not just academic. It is a fundamental skill that saves lives. Understanding the pathophysiology, recognizing the subtle cues, initiating the correct interventions. This guide provides that foundational knowledge, helping you master this topic for exams and patients. We will break DVT into manageable concepts. Basic formation of a blood clot. Complex interplay of risk factors. Verko's triad. Stasis. Verko's triad. Vessel injury. Verko's triad. Hypercoagulability. Diagnostic process. At its most fundamental level, a blood clot or thrombus is a semi-solid mass of blood cells platelets, a protein called fibrin, formed inside a blood vessel. Think of it as a natural repair mechanism gone wrong. Normally, when you get a cut, your body forms a clot to plug the injury and stop the bleeding. This process, called hemostasis, is essential for survival. When a thrombus forms inappropriately inside a vein or an artery without external injury, it no longer serves a protective purpose. Instead, it becomes a dangerous obstruction like a boulder suddenly appearing in the middle of a fast-flowing river, blocking blood flow. This obstruction is the root of the problem. When blood cannot flow freely past the clot, it starts to back up, causing pressure to build in the vessel. This leads to swelling pain and redness as fluid leaks into surrounding tissues. Downstream tissues and organs are deprived of oxygen-rich blood. This reduced blood supply is called ischemia. Prolonged lack of oxygen can lead to tissue damage and eventually tissue death, necrosis. This is the core danger of any thrombotic event in a leg, a lung, or the brain. Why do some people develop dangerous blood clots while others do not? The answer often lies in a classic medical principle known as Virchow's triad. First described by Rudolf Virchow in the 19th century, it outlines three primary factors that lead to thrombus formation. These are conditions that create a perfect storm for clot development. Understanding these components is essential to spot high-risk patients. The first component is venous stasis, slowing or stagnation of blood flow in the veins. Immobility is a major risk factor for DVT. Prolonged bed rest after surgery, paralysis, long-haul flights, long car rides. The leg muscles normally contract to pump blood back to the heart, but when inactive, blood pools in the lower extremities. The second factor is endothelial injury damage to the inner lining of the vessel. A healthy endothelium is smooth and anti-thrombotic. Trauma, surgery, especially orthopedic surgery on the hips or knees. Intravenous catheter insertion, chronic inflammation. Injury exposes underlying tissue and activates the clotting cascade, initiating thrombus formation at the damaged site. Helpful on skin, dangerous inside a closed vessel. Finally, hypercoagulability and imbalance that makes blood more prone to clotting. Causes include genetic mutations like factor V Leiden, cancer, pregnancy, estrogen-based medications, oral contraceptives or HRT. Dehydration can also concentrate the blood. In the United States, DVT and pulmonary embolism affect up to 900,000 people and cause up to 100,000 deaths each year. Identifying a DVT begins with a sharp and focused physical assessment. While some clots can be silent, meaning they produce no noticeable symptoms, many will present with a classic set of signs that you must be able to recognize. The most common manifestations occur in one leg, a key detail that helps distinguish DVT from other conditions that might cause bilateral swelling. When a thrombus obstructs a deep vein in the calf or thigh, blood flow is impeded, causing blood to pool behind the blockage. This increased pressure forces fluid out of the vein and into the surrounding soft tissue, leading to the hallmark sign of DVT, unilateral swelling, also known as edema. In addition to swelling, patients often report pain or tenderness in the affected area. This discomfort can range from a dull ache to a sharp cramping sensation, and it is often described as a Charlie horse that doesn't go away. The pain may worsen when the patient is standing or walking and may be partially relieved by elevating the leg. Upon inspection, you may also notice visible changes to the skin. The affected leg might appear reddish or discolored and feel noticeably warmer to the touch compared to the other leg. It's important to note that the classic Hohmann's sign, pain in the calf upon dorsiflexion of the foot, is no longer recommended as a reliable diagnostic tool. It is not specific to DVT and can be positive in other conditions, while also being absent in many confirmed DVT cases. Relying on it can lead to both false positives and false negatives. Instead, your assessment should focus on the more reliable cluster of symptoms: unilateral swelling, pain, warmth, and redness. An NCLEX tip to remember is this: one leg swelling points strongly toward a local problem like a DVT, whereas swelling in both legs often suggests a systemic issue, such as heart failure or kidney disease. Consider this brief clinical example. You are caring for a 68-year-old male who is 3 days post-op from a total knee replacement. During your morning assessment, he complains that his right calf feels tight and sore. You observe that his right leg is visibly larger than his left. The skin over his calf is slightly red, and it feels warm when you place the back of your hand on it. This combination of risk factors, recent orthopedic surgery, older age, potential immobility, and classic unilateral signs should immediately raise your suspicion for a DVT and prompt you to notify the healthcare provider for further diagnostic workup. The diagnostic process often screens first with a D-dimer, then confirms with imaging, ultrasound for DVT, CT scan for PE. The nurse's role in caring for a patient with DVT is multifaceted and absolutely critical to ensuring a safe outcome. Your responsibilities extend far beyond simply administering medications, assessment, continuous monitoring for complications, implementation of safety precautions, patient education. Your sharp eyes and critical thinking are paramount in detecting subtle changes in the patient's condition. A primary nursing responsibility is the careful monitoring of anticoagulant therapy, heparin, a low molecular weight heparin, B, direct oral anticoagulant. While these drugs are essential for preventing the clot from growing, they also carry a significant risk of bleeding. You must continuously assess for signs of bleeding, nose bleeds, blood in the urine or stool, or subtle signs like bruising, petechiae, or a new severe headache. Monitor lab values like APTT for heparin and platelets for heparin-induced thrombocytopenia. For example, if you see pink or red urine in the catheter bag, this is a critical finding. And this sign of hematuria requires immediate attention. you would first ensure the patient is stable, then pause the heparin infusion according to protocol, and notify the healthcare provider immediately. Swift action can prevent a minor bleed from escalating into a major hemorrhage. Once a DVT is diagnosed, interventions focus on three main goals: preventing enlargement, preventing embolization, and preventing complications of treatment. Administer anticoagulants safely, LMWH, like enoxaparin or an oral anticoagulant. Ensure the correct dose, use proper injection technique, and educate on the medication's purpose. Monitor vigilantly for signs of a pulmonary embolism, sharp stabbing chest pain, shortness of breath, a rapid heart rate, or a drop in oxygen saturation. These are red flag symptoms of a PE. Your first action: sit the patient upright to ease breathing, apply oxygen, and call for immediate assistance from the provider or rapid response team.
He suddenly gasps, clutches his chest, and says, "I can't breathe." Your training must kick in instantly.
High Fowlers, check SpO2, apply supplemental oxygen, hit the emergency call bell, and reassure the patient as help arrives. While our primary focus in managing DVT is rightly on the immediate physical dangers, pulmonary embolism, bleeding, we must not overlook the significant psychosocial impact. Being told you have a potentially life-threatening blood clot can be frightening and anxiety-provoking. Patients may fear the clot traveling, become hypervigilant about aches, have difficulty sleeping, a poor appetite, or feel irritable and on edge. Recognize these responses as normal. Provide emotional support and a safe space for questions. After a major PE, some may experience intrusive thoughts, nightmares, or avoidance. Screen for anxiety, distress, or depressive symptoms. Interventions include listening, clear explanations, teaching relaxation and deep breathing techniques, and involving family for support. Effective patient education is vital. Emphasize strict anticoagulant adherence. These medications prevent the clot from growing and new clots from forming. For example, you might say, this medication helps to thin your blood just enough to keep dangerous clots from forming while your body works to dissolve the one you have. Teach bleeding precautions. Major signs like red or black stools, red or brown urine, severe headaches, coughing up blood. Minor signs like nosebleeds, bleeding gums, increased bruising. Use a soft bristled toothbrush and an electric razor instead of a blade. Review hydration, avoiding long immobility, simple leg exercises on trips, and post-op, continuing compression stockings or prescribed devices. Ensure the patient knows when to call or seek emergency care, and provide a written summary to support recall at home. Case scenario: a 78-year-old female from a long-term care facility with cough and fever, chronic heart failure, osteoarthritis, hypertension, weak, poor intake, and a slightly more swollen, tender left calf. Which factors fit Virchow's triad best? Option 3 is the best answer. Immobility causes venous stasis. Dehydration increases hypercoagulability. Chronic heart failure adds to stasis, the perfect storm for DVT formation. When unsure, assess for complications first. Throughout this comprehensive overview, we have journeyed from the microscopic formation of a thrombus to the life-altering reality of a pulmonary embolism. We explored the critical importance of recognizing risk factors through the lens of Virchow's triad. We mastered the subtle signs of a DVT, and we understood the diagnostic and therapeutic pathways that follow. The nurse's role is central, acting as a vigilant assessor, a careful administrator of high-risk medications, a patient educator, and a compassionate supporter. The connection between a deep vein thrombosis in the leg and a pulmonary embolism in the lungs is a pathway paved with peril, one you are uniquely positioned to interrupt. Every time you assess for unilateral swelling, reinforce ambulation, or educate on signs of bleeding, you bend that pathway towards safety. The responsibility is significant, but your training and critical thinking skills are powerful tools. By applying the nursing process methodically, you can bring order and safety to a potentially chaotic clinical situation. Remember the clinical examples: the post-operative patient with a swollen calf and the patient on anticoagulants who suddenly develops chest pain. These scenarios are realities of nursing. Your vigilance is your patient's greatest safeguard. This guide has aimed to equip you for DVT-related challenges, both on the NCLEX and at the bedside. The core principles are clear. Understand the risks, know the signs, and be prepared to act. As you move forward, let this knowledge sharpen your assessments and guide your judgment. Of all the lessons to take away, the most vital is this: when in doubt, prioritize assessment for complications.